I'll be talking on CAR T cardiotoxicity at the BSH conference this year. The reason I've been asked to talk about that is it's an emerging area of concern for both hematologists as well as for cardiologists. We're seeing an increasing number of patients using this new therapy. It's moved from the trial arena to very much use in NHS patients. And the use is expanding from hematology patients to other malignancies and sometimes potentially for use in non-malignant conditions as well. Now, what we have seen is that a fair proportion of patients do develop a cardiotoxicity. In an analysis we did of the FAERS database, we found that around 20% of patients developed a cardiotoxicity. And as such, it's quite important that the treating physicians, the hematologists, oncologists, cardiologists are aware of the toxicities and how best to maybe try and prevent them and manage them when they occur. Because it's an emerging area, the amount of data that we have is growing. We have some understanding that these patients have, as I mentioned, around a 20% risk of a cardiotoxicity. The majority of those cardiotoxicities are heart rhythm related, although there are some patients who have severe cardiotoxicity in the form of cardiac dysfunction, and there has also been cardiovascular death, unfortunately, associated with some of these patients. So what this means is that all the practitioners need to be aware of the potential of developing these issues and how best to manage them. Now, what we've seen over the course of the brief period of time that the CAR T cell treatment has been in place is that the management of the side effects has changed. So whenever a patient develops the commonest side effects, which are part of the cytokine release syndrome or CRS, what we see is that the hematologists are moving to use the IL-6 blocker tocilizumab quite early on. Now, what this has meant is that a lot of the severe toxicities are no longer seen because quite intensive treatment to prevent the toxicity with the tocilizumab is now being given quite early on. Now, this is, of course, good for the patient, not just from the cardiac side, but a lot of the other more significant grades of CRS are now no longer being seen. But there are still some patients who develop heart failure. There's some patients who develop significant rhythm issues, often bradycardias, low heart rate, sometimes tachycardias. And really, with more ongoing studies in the clinical arena, in the real world arena, we are getting a better understanding of how best to manage these patients. And as I mentioned, given that tocilizumab is being used earlier, that probably is one of the best management strategies, not just for the cardiotoxicity, but for all forms of the high grades of CRS.